just a few patches of very minor inflammation, and as we know, we can get some periappendiceal inflammation with ulcerative colitis, but there's no significant disease over here. In the ascending colon, we've identified one area here which is a little bit inflamed, and the question we have is we need to determine if this is just inflammation or if this is dysplasia. Because obviously inflammation can be present, even patchy, in ulcerative colitis patients. And to me, we need to use our different modes of imaging. So I've got the Olympus 1500 series colonoscope that I'm using today, and that's got the capability of obviously the narrowband imaging, or NBI, which is, in my experience, equivalent to dye spray chromoendoscopy. So I don't tend to use dye spray chromo in my IBD surveillance patients. I use NBI alone because I think it's not. There's no studies showing equivalency yet, but there are non-inferiority studies coming out. So I think if you don't have the ability to do chromoendoscopy, which still remains the gold standard, then virtual chromo is a good alternative. So here we come in and examine this area, and it can be difficult to tell whether this is inflammation or dysplasia, even on NBI. And I don't think I've got zoom here, but I'll try to get a good steady picture without the bubbles. In the center, you can see some abnormal vessels and some, but this to me looks like it's more inflammatory. There doesn't look like any neoplastic or dysplastic change within this, but we obviously will need to take biopsies as per the protocol, 4 quadrants, 10 centimeter biopsies throughout the colon, because of that risk of invisible dysplasia, as we've heard in the talks. So there are a few patchy changes in the ascending colon. Here's another one just up here. You can see also looks inflammatory. Doesn't have the typical appearance of dysplasia, but we can't necessarily exclude that just on the endoscopic appearance alone. So we will need to take biopsies from this area. But we can do that after the case. So I've examined, so here you can, I've already withdrawn using a combination of both the white light endoscopy and the narrowband imaging, and I think that's important to do both because you can see different changes with the different imaging modalities. So I think it's very important to do withdrawal in each segment using white light, high definition, and then using narrowband to again withdraw from that segment. So we can come here and we can see very nice normal appearing mucosa, normal vascular pattern, no evidence of any active disease in this area, which would be consistent with his history. And so we keep withdrawing, and then there was, I'll change it back through to white light imaging again. So here we're back on the white light. And we continue to slowly withdraw. And obviously the key with any IBD, as with any colonoscopy, is examining the entire mucosa, or as much as we can see, because here you can see there's what we likely suspect is a sessile serrated adenoma. So these patients obviously are at risk of normal neoplastic lesions such as SSA or SSD or tubular adenomas, etc. So we're not just looking for the dysplasia in these patients. We need to do normal, treat them like with the normal for polyps that we see. And in these cases, with the mucus cap obviously gives you a slight clue as to the presence of the SSA underlying that area. So I don't tend to wash the mucus cap off straight away, because until I'm ready to do the polypectomy, I'll keep the mucus cap there, because it's one thing that will help guide me as to where the lesion is. Often if you remove the mucus cap, then the lesion actually becomes very, very difficult to see. With our AI modes that we now have on several of the scope platforms, SSAs I find are very difficult. The AI doesn't necessarily pick up SSA very well. So I think we are still reliant on optical diagnosis rather than AI